Well, we're back with podcast number 4. This is Dan Limmer and Joe Mistovich. Hopefully you've heard the introductions in podcast 1, 2, or 3, so I think we'll skip those this time and get right to what we're doing. This podcast is the second in our series on the actual details of pathophysiology. Podcast number 3, we talked largely about ventilation, about ventilation perfusion mismatch, and how oxygen, how air comes in and out, the mechanics of ventilation, and that's vitally important. Cells will die without oxygen and glucose, and perfusion is the act of getting that to the cells. So ventilation is the important first part, but unless we can actually perfuse the body and get those vital components out to the cells, the patient will die. So in this podcast, we want to talk about the act of perfusion, how it works, things like vascular tone and the way the circulatory system works and adjusts itself, that normal physiology, and then talk about shock and some of the pathophysiology of what happens when that goes badly and what happens to the patient.
Absolutely, Dan. And, and we talk about perfusion, and perfusion there's a lot of variables and components to perfusion. And, even in the shock patient, we always say, shock is not a low blood pressure. And that's absolutely true. And I'm not advocating, going back and saying, oh, gee, shock is low blood pressure. Shock really is inadequate tissue perfusion. And as you had indicated, it's not getting an adequate amount of oxygen or glucose to the cell. But we do have to realize that one thing that drives that blood flow to the cell is pressure. And that pressure is the blood pressure. And so that is a large component when you talk about, hemodynamics and the hemodynamic status of the patient, that blood pressure plays a major role. And we'll find out, as you said, the vascular tone, how that vascular tone changes will change the pressure, and also volume. The volume of blood will change the pressure. So going back and saying, we can't look at blood pressure to determine perfusion. Well, we don't want the blood pressure to be the only determinant of perfusion, because I think after we get done with this podcast, hopefully the EMT will realize that you could be deceived into thinking that the cellular perfusion is good by looking at blood pressure, because the body's changing things to try to maintain that pressure so it could maintain perfusion. But also what you'll find out is that it's doing it at the expense of tissue and cells. So as the body loses more volume, the body will continue to cut off perfusion to other areas, especially the skin, skeletal muscle, and so forth, to maintain that pressure. And so by understanding these components, I think, again, the student will be able to understand the different types of shock and how that shock is actually going to lead to poor tissue perfusion.
Joe, that really makes me think. My role here is kind of the big picture and the assessment things, and you do the detail stuff. But let's just talk really quickly. When we talk about perfusion and the effects on the body, we think about the brain. That when people don't perfuse well, we see that on the outside. You've talked about the pale skin we might see and other things, but if the brain doesn't get oxygen and glucose, if we're not perfusing the brain, it's profoundly intolerant to that. And altered mental status is one of the first things that we see. We can generally see a lack of perfusion long before the blood pressure in many cases, and that the way we look at the patient and see that, much like we look for ventilation issues, we can tell when perfusion isn't good, right?
Absolutely. And one thing, Dan, which we're beginning to emphasize more and more and more, especially in the shock patient, is to assess vital signs as one component, however, assess signs of shock as a separate component. And it's kind of interesting because you say, well, aren't the signs of shock including the vital signs? Yes and no, but it's exactly what you're saying. Signs of shock outside of the vital signs, actually, and these are really signs of perfusion is what they really are, these signs of perfusion actually will show a lot sooner than maybe the changes in the vital signs. And so what you're saying, extremely important, alteration of mental status, that anxiety that the patient presents with, well, that's a huge red flag. The patient now that starts looking a little bit tired, a little bit sleepy, that's a huge sign. The pale skin, the cool skin, major sign, because you know what's happening now is the vital signs, as you said, Dan. The blood pressure the body's going to change in order to try to maintain that pressure, but it's doing it at the expense of other cells and tissue. It will shut off areas of the body to try to maintain that pressure. So what we're seeing in the signs of perfusion are those areas being shut off. In the vital signs, they're still going to look relatively normal. Here's a good example. And we always teach students, well, in the shock state, for the most part, in general, especially in the hypovolemic shock patient, we're going to see the blood pressure go down, and we're going to see the heart rate go up. And we're typically going to see the respirations go up. Well, what's happening now, and I read one study where they found 35% of the patients in hypovolemic shock weren't tachycardic. 35% of the patients weren't tachycardic. And for me, that's so, it's so profound, because we beat into students' heads, if they're hypovolemic, look for a drop in blood pressure, look for that tachycardia, and that tachycardia is going to be an early sign before the blood pressure falls. But now we're saying 35% of the patients, their heart rate's not going to go up. And what they're attributing that to is now all these patients on beta blockers and calcium channel blockers. That's keeping the heart rates from going up. So if you have a student that goes in, let's say there's a car crash, and your partner, you say, okay, get a set of vital signs, and your partner says blood pressure is 102/88, and you think, well, that's within the normal range, and you don't bother to pay attention to the pulse pressure, and they say the heart rate's 74, and you go, well, that's in the normal range too, and the respirations, they're 22, and you go, well, they're probably excited a little bit, that's why they're breathing fast. And you say, well, this patient's obviously not in trouble, but yet the patient, as you said, is anxious. Their mental status is becoming altered. They're pale, they're cool, they're clammy, and you fail to look at that. Boy, you've just missed a hypovolemic shock patient because you relied solely on the vital signs.
Well, one of the things you said that I've found interesting was just recently teaching some of my students. You had a little concept in there about pulse pressure. So to build up to that, because anyone who was listening heard that little clue and noticed the pulse pressure change. With minute volume, back when in the last podcast talking about ventilations, there's an equation that we have the number of breaths per minute and the tidal volume. Well, there are some equations for perfusion as well that we can determine cardiac output, and blood pressure is basically a series of, I'm not talking about mathematical equations that we're ever going to be able to measure, but I think those concepts build up to understanding this physiology of perfusion, that the amount of blood we put out of our heart per beat and per minute, and the way our vascular tone, our vascular resistance works, that's ultimately the back and forth and how our body adjusts and maintains blood pressure.
Absolutely. And so if you can understand the equation, and we call it an equation, but as you said, Dan, we're never going to expect anybody to calculate this, but if you can understand these equations, you start understanding why the patients are presenting how they're presenting. And you can then recognize in your assessment changes. So when you're with your patient and you notice that the heart rate has gone up now 10 more beats per minute, there again is a red flag for you to say, obviously this patient is continuing to lose blood because the body's trying to compensate for that blood loss by raising the heart rate. So, you want to talk about the equations now?
Let's do it. Let's do cardiac output and blood pressure, and then from that, let's get into the details.
Okay, so if your blood pressure, you take a blood pressure. We know there's two components to a blood pressure. There's a systolic blood pressure and there's a diastolic blood pressure. The systolic blood pressure basically is the pressure inside the artery while the heart is contracting. So when the heart contracts, when the left ventricle contracts and it shoots that wave of blood through the arteries and the arteries are expanding, there's an increase in pressure because the heart basically is pumping or ejecting that blood through those arteries. So the pressure goes up during that contraction phase. That's what we refer to as the systolic blood pressure. The diastolic blood pressure is actually the pressure in those arteries in between contractions. And a lot of times you hear it referred to as it's the pressure in the arteries when the heart's at rest. Well, that's the diastolic phase. That's basically between the contractions. The arteries maintain a tone. And you had mentioned a tone earlier on, and what that tone basically is related to is vessel size. The smaller the vessel size, the greater the tone, the higher the resistance. The bigger the vessel size, the lesser the tone, and the lesser the resistance in that artery. So when we look at the blood pressure, and we take the systolic and the diastolic, it's basically a full cardiac cycle. When the heart contracts and then there's relaxation, that'd be one full cardiac cycle. Well, in the cardiac cycle, about 1/3 of it is systole, the heart contraction, and 2/3 of it is diastole, that relaxation phase when the heart's not contracting. And if you take the both of those, basically what you get is a mean pressure. All right, so when we look at blood pressure now, there are two components that primarily make up blood pressure: cardiac output and systemic vascular resistance. So if you take blood pressure and you want to calculate it, you take cardiac output times the systemic vascular resistance. Okay, let's talk about cardiac output for a second. The definition of cardiac output basically is the amount of blood ejected from the left ventricle in 1 minute. And that's cardiac output. So the amount of blood that's being ejected each minute out of that left ventricle will determine the cardiac output. So if you look at cardiac output, really what it is basically determining is the effectiveness of the blood being ejected out of the left ventricle. And so when you look at cardiac output, there's a couple components to it then. You say, okay, so what now would contribute to the effectiveness of that blood being ejected out of the heart? Well, cardiac output then has two components: heart rate and stroke volume. Heart rate is obviously how many times the heart beats in a minute. Stroke volume, though, is the amount of blood that's ejected from the left ventricle with each contraction. Okay, so cardiac output has two components: heart rate and stroke volume. The beats per minute times the amount of blood that's ejected from the left ventricle with each contraction of the heart. So now you look at stroke volume and say, well, now, what's going to change stroke volume? Well, there's three components to stroke volume. Preload, there's myocardial contractility, and then there's afterload. Now, preload basically is the volume of blood that fills that left ventricle right before it contracts. The myocardial contractility is the effectiveness of the contraction. How hard, how forceful is that contraction of the left ventricle? And the third is afterload. Afterload, actually, you can read some different definitions for afterload, but for the most part, what it is the pressure that is found at the aortic root in the aorta when the left ventricle contracts that it has to overcome. One thing, Dan, high blood pressure, and a risk factor of high blood pressure long term is heart failure. And so a lot of people, they're really worried about the diastolic blood pressure when they go to the doctor, because the diastolic blood pressure, a lot of times, if it's high, the long-term effect of that might be heart failure. And the reason being is, if you think about it, I already said that the diastolic blood pressure is the pressure in that artery between contractions. So that means when that heart contracts, it has to actually pump out against that diastolic blood pressure. It has to overcome that diastolic blood pressure.
It has to work harder, and it's a muscle. The muscle will only work that much harder for so long.
Absolutely. Okay, so now, you bring up the point, it's a muscle. And what it is that diastolic blood pressure is based on resistance. And that resistance is, for the most part, the vessel size. Okay, the higher the resistance, as you said, the harder the heart has to work. Here's an analogy. If you take a person and you give them a 2-pound weight in their left hand and you give them a 10-pound weight in their right hand, and you tell them...
That's actually what I'm doing right now. I'm exercising while we're done.
And you tell them to lift the weights, okay, what arm will fail first, 2 pounds or 10 pounds? What's interesting, I always say is, okay, when you do weight training, what is it called? It's called resistance training. Because what you're doing is you're working your muscles against resistance. How do you apply the resistance of weight training? You increase the weight. And so, but it's the same thing, it's resistance. And you say, okay, how does the muscle work with resistance? Well, if there's low resistance, the muscle is going to continue to be able to work and work and work. But if you take a 10-pound weight and you tell that person to lift it, okay, versus a 2-pound weight, which muscle is going to fail first? The 10-pound weight. Why? Because they're having to lift it against a much higher resistance versus a 2-pound weight. So, again, making that analogy and referring it back to the heart's a muscle, as you said. And the higher the resistance, the harder the heart has to work. And over a long period of time, the harder that heart has to work, it's going to fail faster. So therefore, a person who has high diastolic blood pressure over a long period of time will be very prone to heart failure, where that left ventricle is eventually going to start failing because it has to beat against that high resistance. And that's that afterload component. Okay, so now, Dan, big picture. You say, okay.
Hey, you're doing the big picture?
Well, let's apply some of these components to the big picture. And you say, okay, look at the blood pressure. You say, okay, cardiac output is the first component. And we know cardiac output is heart rate and stroke volume. Stroke volume is preload, the amount of blood that ends up in the left ventricle. Now, you know what's interesting? You know what's the big determinant of preload is venous volume, because the venous side is our reservoir. You know, so if we go back to the analogy in the previous podcast, and we take the guy that sliced his radial artery on a piece of glass, you know what's really going down? Not the arterial volume, it will go down, but the venous volume. But as the venous volume goes down, what that means is it puts less blood in that left ventricle before it contracts. So if we have less blood in that left ventricle when it contracts, that means we're ejecting out less blood into the arteries. So what happens? That volume goes down. That pressure goes down because we're ejecting out less volume. So preload is really determined by venous volume. The amount of blood coming in the right side of the heart will determine how much blood ends up in the left ventricle right before it contracts. But if that preload goes down, so does the cardiac output. So does the blood pressure.
So to increase our blood pressure, we have in the first part of this equation, in the cardiac output part of the equation, and the people listening to this, you know, will get this, is that when we see this, as you said, we don't always see it in shock, but we have a couple options, and it's really our sympathetic nervous system that really kicks in both of those options for us to increase our heart rate and to increase the efficiency and the squeeze of our heart. Is our first attempt is to improve cardiac output that way.
It absolutely, because here's the thing. Blood pressure is equal to cardiac output times systemic vascular resistance. We haven't talked about the resistance yet, in any detail, but let's go back just to the cardiac output. So if my cardiac output goes down, I would expect my blood pressure to go down. If my blood pressure goes down, I expect perfusion to be poor. Okay, it's the same thing with systemic vascular resistance. If the let's talk about it now. The systemic vascular resistance is just that. It's resistance, the resistance you find in the arteries. And as you mentioned earlier, Dan, that resistance is actually based on tone, and that tone of that vessel. So that means if we take a vessel and we dilate it, we make it larger in diameter, the resistance goes down because the space is bigger, and so there's less resistance to blood flow. And so what happens? If we make that vessel bigger because it dilates, the systemic vascular resistance goes down. If we take that vessel and we constrict it, we increase the resistance to blood flow, and the SVR goes up. Okay? In general, if you look at blood pressure, if we increase cardiac output, we can increase blood pressure. If we increase SVR, the resistance in the vessels, we could increase blood pressure. If we increase blood pressure, we could actually maintain or increase perfusion. On the opposite end, if we decrease cardiac output, we usually will see a decrease in blood pressure. If we decrease the SVR, we could see a decrease in blood pressure. So now all of a sudden, these students start putting this together with shock and with medical conditions and say, here again, we don't expect students to memorize signs and symptoms. We expect them to figure them out. And so we say, okay, let's go back to this example. Let's take the patient now who lacerated his radial artery, and now he's bleeding out all over the carpet. And we said, well, if he's bleeding all over the carpet and it's an arterial bleed, it doesn't matter. This patient's going to be reducing his venous volume to make up for that blood loss. Well, if he's bleeding out onto the carpet and reducing his venous volume, what does that mean about the amount of blood that's coming into the right side of the heart? It's going to be decreased. And if the blood coming in the right side of the heart is going to be decreased, that means the amount of blood that fills the left ventricle before it contracts is also going to be decreased. Well, if that volume's decreased, when that heart contracts, it's doing what? Ejecting out less blood with each contraction. So what goes down? The stroke volume. Well, if the stroke volume goes down, so does the cardiac output. And if the cardiac output goes down, so does the blood pressure. So now, Dan, you said, okay, so what happens in this patient? Well, if the stroke volume is going down because this patient is ejecting less blood with each contraction, the body wants to increase the cardiac output. So how does the body increase the cardiac output? Because the stroke volume is going down, what's the other component to cardiac output? Heart rate. So what's the body going to do to try to make up for the decrease in cardiac output? Increase the heart rate. Take that patient who lacerated his radial artery. What do you normally see in a hypovolemic shock patient? Tachycardia. Why is the patient tachycardic? Because they're losing blood volume, their stroke volume is going down. To try to compensate for it, they're increasing heart rate. Okay? Now we go back to the big picture of blood pressure. As the cardiac output goes down, so does the blood pressure. Now the body, again, wants to do what? Keep that blood pressure up, because that blood pressure is going to maintain perfusion. So what does the body do? Well, cardiac output's going down because the patient is losing the blood onto the floor, and the heart rate's not going to make up for that drop in cardiac output, so the blood pressure is going down. What's the other component to blood pressure? Well, the first one is cardiac output. The second, systemic vascular resistance. Okay? Remember I said earlier, if we increase resistance, we can increase blood pressure. So what does the body do? How do we increase resistance? We decrease the vessel size. We decrease the diameter. And what happens? We increase the resistance. By increasing SVR, we can increase the blood pressure, even though the patient is losing blood onto the ground. So now we look at the blood pressure and we say, how is this blood pressure being maintained? You know, here again, Dan, early on you said, what do you want to look at? Look at mental status of the patient. Look at the skin. Look at the oral mucosa. Look for pale, cool, clammy skin. Look for signs of perfusion and not necessarily the vital signs, because you know what? This blood pressure is going to be maintained for a period of time. How is it being maintained? Patient increased the heart rate to try to maintain cardiac output, and now the patient is constricting vessels, their arterioles, their arteries, and some veins and venules to try to increase the SVR. So now you look at the blood pressure, and I mentioned earlier, patient has a blood pressure 102/88. And if you look at it, and I know we've talked about normals, and we have to have a podcast one day, Dan, on normals, because I know we both say normal is only normal for that patient. But if you said, you know, if I asked you, Dan, is 102/88 normal?
Joe, anybody asking me what's normal is probably flawed, but I guess that's another story.
Well, and that's true too. So maybe that's a bad question. But no, seriously though, Dan, when you're teaching vital signs early on in your EMT class, and you say a normal systolic blood pressure is 100, to 140, and a normal diastolic pressure is normally between 60 and 90. And if I said, Dan, is 102/88 normal? A typical response is going to be yes, because it falls within the normal limit. But when you look at the patient losing blood and you say, is 102/88 normal? I'm going to say absolutely not. Here's the thing. When you look at the systolic blood pressure is basically measuring somewhat the cardiac output of the patient, the first component in the blood pressure. The diastolic blood pressure really is measuring that vessel tone, the SVR. So systolic blood pressure is measuring cardiac output. The diastolic blood pressure is measuring systemic vascular resistance. Okay, so now think about it. We already said the cardiac output is going down because this patient is losing blood. The patient's not ejecting as much blood out of the left ventricle, so the cardiac output's going down. Sure, the patient's trying to compensate for it by increasing heart rate, and we're going to see that in the patient. But the cardiac output's going down. So in the big blood pressure equation, if the cardiac output's going down, how do we try to maintain the blood pressure? Well, let's push up the systemic vascular resistance. How do we do that? We constrict vessels. What's a measure of the SVR? Diastolic blood pressure. What's a measure of cardiac output? Systolic blood pressure. So now if you could visualize this and put the systolic over the diastolic and draw an arrow down over the systolic, because the cardiac output's going down, and if you could take the diastolic blood pressure, put it on the bottom, and draw an arrow up, because the resistance is getting greater, the vessels are constricting to try to preserve that blood pressure, that pressure is going up. So you take the two arrows, and what are they doing? They're coming closer and closer and closer together. That's your pulse pressure. The systolic minus the diastolic blood pressure.
Yep, narrowing is, narrowing or closing or, getting closer together. Is a really great sign of shock that that many people, as a result of the way things had been taught previously, they never got. It was another memorization thing. The pulse pressure, may narrow. And it's really amazing that we've never taught it in this detail, because it really is that important.
Exactly. Now, in general, a normal pulse pressure is typically around 30 to 40 millimeters of mercury. That means if you take the systolic blood pressure, subtract the diastolic, the difference between those two numbers is about 30 to 40 millimeters of mercury. Okay, Dan, so we go back to that, well, whatever. Let's go back to the patient who slices radial artery or car crash, whatever it be, and I say, Dan, what's the patient's vital signs? And you tell me 102/88. Now, knowing this and how the blood pressure is affected by the cardiac output and the systemic vascular resistance, although 102 is within the normal range of the systolic blood pressure and 88 is within the normal range of the diastolic blood pressure, what I'm going to look at is I'm going to say, but boy, aren't those two numbers, 102 and 88, getting real close together? And that's what I'm going to look at, even though that blood pressure falls within the normal range. I'm going to say that pulse pressure is becoming awfully narrow, meaning what? The cardiac output's going down and the systemic vascular resistance is going up. That's what I'm going to pay attention to more, along with my signs of perfusion, mental status, again, skin perfusion, capillary refill, and skin signs and symptoms, and capillary refill. And this is why this equation makes, hopefully will make sense to the EMTs to say, don't pay so much attention to the actual numbers. Pay attention to the difference in the numbers. Once they fall, it's obvious. But these are the early signs of shock.
Yeah, and I think that even less experienced people could be fooled by the fact that it appears that the blood pressure goes up when the body kind of compensates like that. It can actually be a very false sense, because that compensation won't last forever. That vascular tone will only stay for a certain period of time. We'll only be able to make up for the blood loss for a certain period of time.
Absolutely. But, just knowing that as the cardiac output goes down, the blood pressure goes down. As the SVR goes down, the blood pressure goes down. If you try to raise the cardiac output, you're trying to raise the blood pressure. Okay, Dan, let's do big picture here again. So we have a patient who's having a heart attack, having an MI, and their SA node is affected by this heart attack. It's ischemic, whatever it is, and now their heart rate is down to 32 beats per minute. Well, okay, let's apply that. And now the students, and see, this is how we want them to think through this. So if I pose this question to a student, say, you got a patient having a heart attack, and the heart rate's 32, what's going to happen to blood pressure? Well, what they do is they say, okay, wait a minute now. Okay, heart rate. Heart rate is part of cardiac output, right? And we said if the heart rate goes down or the stroke volume goes down, cardiac output's going to go down. Heart rate's 32. Heart rate's really low. What's that going to do to the cardiac output? Cardiac output's going to go down, okay? And when the cardiac output goes down, what happens to their blood pressure in this patient? Oh, if the heart rate's 32, I would expect to see a drop in blood pressure, okay? So if the cardiac output goes down, what does the body do to try to compensate for that drop in cardiac output and that drop in pressure? It's going to raise the SVR. So then you say, okay, well, if the systemic vascular resistance is going up, the only way the body can do that is to do what? Constrict the vessels. Which vessels get constricted first? Arterioles and arteries in the skin. The patient who's having a heart attack with a heart rate of 32, what are the skin signs going to be? Pale, cool, and clammy. Pale and cool because what are you doing? You're taking all that nice warm blood that was in the periphery, and what are you doing? You're constricting those vessels and shunting it to the core of the body. And see, in this patient with a heart rate of 32, the student doesn't have to memorize that you would expect to see a drop in blood pressure or that you're going to see pale, cool, clammy skin. They're actually going to be able to figure it out.
I understand how it fits in the equation. Well, let me do one here. I don't think I want to make sure I get my speaking part in this because you've been doing so well. How about anaphylaxis? How about we take anaphylaxis and then we increase the size of the vessels? That's one of the other variables in this. And anaphylaxis is one where we take and through that allergic reaction, we increase the size of the vessels. We take the same amount of blood but we increase the size of the container. The vascular resistance changes, because ultimately what we're doing here is we're going through all the different causes of this, because there's the blood itself, and then there's the pump, and then there's the size of the vessels, are three variables in this. And we can find that our blood vessels, whether it be a neurological cause of shock or anaphylaxis, we can dilate our blood vessels, lose the vascular resistance on that part of the blood pressure equation, and still have shock.
Absolutely. You know what's interesting, Dan? So then you pose this question to the student, and you know, here's the beauty of this. So you go into class and you say, okay, we're going to talk about anaphylaxis today, and so what's some of the pathology associated with anaphylaxis? And you say, vasodilation, the vessels dilate, and the capillaries leak, and fluid is leaking out of the capillaries. And so you say, so what are you going to see? And as you're saying, well, the students sit there and go, well, wait a minute, the vessels are going to dilate. That means they're becoming bigger, so therefore the resistance is going down. SVR is going to go down. Well, the blood pressure is going to go down. Right. Why is the blood pressure going down? Because the vessels are dilating and they're losing the resistance. Okay? And then you say, okay, and the capillaries are leaking. Well, if the capillaries are leaking, they're losing blood volume. They're losing the plasma part of the blood volume. But if they're losing volume, what happens to cardiac output? Well, stroke volume is the volume of blood in the left ventricle with each contraction, so that stroke volume must be going down. Right. Well, if the stroke volume goes down, what happens to the cardiac output? It goes down too. What happens to the blood pressure? It goes down even more. Right. Okay, and then you say, well, because you're losing volume and your SVR is going down, what's one way the body's going to try to compensate for that loss of volume? How are you going to try to increase cardiac output? Well, the stroke volume's going down. The only other way to do it is raise the heart rate. Right. So you say, oh, look at that. In anaphylaxis, the student has already figured out blood pressure is going to fall, heart rate's going to go up, and if they're vasodilating, where's all that nice warm red blood? Out in the skin. Because the vessels are dilated, so their skin's going to present as being warm and flushed.
There's really those three factors, the heart rate, the stroke volume, and the vascular resistance, that just become a part of all this. And understanding those, really, what pathophysiology does is it changes, really, if you have this pathophysiology lecture early in your EMT class, it affects the way you have your cardiac lecture and your respiratory lecture and your anaphylaxis lecture and your shock lecture. It really changes the foundation of everything from memorization to understanding. It weaves through the entire curriculum.
Oh, absolutely. And you can apply this to really understanding anything. You know what's interesting, Dan? You mentioned respiratory. And somebody would say, well, how does this apply to respiratory? How does this equation, as cardiac output and SVR, apply to a respiratory condition? Well, here's what's interesting. When the brain's becoming hypoxic because the patient's having an asthma attack, and we already talked about that ventilation perfusion disturbance in the previous podcast, and they say, well, there's not enough oxygen getting to the cells. Well, if there's not enough oxygen getting to the cells, it's the brain too. When the brain starts becoming hypoxic, the brain, as part of the medulla, has a vasomotor center. Vaso, referring to vessel, motor, referring to movement. The vasomotor center basically controls tone of the vessels, primarily the arterioles and arteries. And so what happens? When the vasomotor center becomes hypoxic, it's telling the brain, I'm not getting enough oxygen. Well, what's one way to increase the oxygenation of the brain? Send more blood there. Well, how do you send more blood to the brain? You have to do what? Improve the perfusion. Well, how do you improve the perfusion of the brain? You have to do what? Increase the pressure to increase the blood flow to the brain. You say, well, so what does the body do to try to increase the pressure to improve the perfusion of the brain? It constricts vessels. Because we know what? By constricting the vessels, what goes up? SVR. And as SVR goes up, the blood pressure goes up. You know, Dan, if you look at a hypoxic patient, what's an early sign of hypoxia? Pale, cool, clammy skin. Why is their skin pale, cool, and clammy? Because the vasomotor center is constricting the vessels to drive up the SVR to try to drive up the blood pressure to better perfuse the brain. Mm-hmm. So the late sign is cyanosis. The early sign is an increase in SVR causing pale, cool, clammy skin. And that's how this is all drawn in, and that's how these students need to really integrate this in and learn this. Dan, we could say, cardiogenic shock. You could present this basic principle and walk into the classroom and say, cardiogenic shock. What happens in cardiogenic shock? Well, let's say in this cardiogenic shock, the left ventricle is failing. The heart can't generate enough force to eject all that blood. You say, well, where does that fall? Well, cardiac output. Okay, cardiac output, heart rate times stroke volume. Stroke volume, remember, was preload, myocardial contractility, the force of contraction, and afterload. So, well, which one's disturbed? Well, in a patient who had a heart attack that had a large MI that affected the left ventricle, now the left ventricle is really weakened and can't contract forceful enough. Did that patient lose any blood volume? No. So, okay, so it's not stroke volume, but the heart can't contract forceful enough. So what's driving down the stroke volume? A decrease in contractility. What happens if we decrease stroke volume? What happens to cardiac output? It goes down. What's the other component of cardiac output? Heart rate. If our cardiac output's going down because our stroke volume's going down, what do we expect the heart rate to do in the heart failure patient? Go up, because it's trying to make up for the drop in the cardiac output. So you say, okay, let's plug now cardiac output into the blood pressure in this patient. Well, their contractility is decreased, so their cardiac output's down. The body's trying to make up for the cardiac output by increasing the heart rate. So the cardiac output's going down, so the blood pressure is going to go down. How does the body compensate for that drop in blood pressure? It constricts the vessels to raise the SVR to try to raise the blood pressure. So, signs and symptoms in this patient: tachycardia, pale, cool, clammy skin, a narrowing pulse pressure. These students can figure it out. They can figure out the signs and symptoms.
I mean, I think that this really gets to, when coming, for a full circle now, our time is almost up for this podcast, but coming full circle, I really do hope that this gave us the ability to understand rather than memorize. Now, with the description that you've given, Joe, that students at the EMT level, because in the past things have always been kind of, well, you don't need to know this is just what to look for, and both of us fundamentally believe that EMTs have the ability to understand and the necessity to understand that this really makes a difference in treatment, that understanding. I think this is great for the individual EMT. I think it's great for the profession that we're now teaching this understanding, that we're doing it this way, and it's my hope. I know it's our hope that in wrapping up this presentation, that our talks on ventilation and perfusion has helped instructors have some ideas how to present this, and for students listening to really be able to say, "Wow, now I get it," because that's really our goal. And if you get this, your patient care will be better, and it's just so important.
Absolutely. One thing, Dan, matter of fact, my students laugh at me, and they've made sweatshirts up and so forth, because I always say it all makes sense. And by knowing some of this basic information, normal physiology and pathophysiology, you can figure it out because it all makes sense. And you're right, Dan. EMTs, in the past said, well, what do we need to know this for, know this, and so forth. We've done somewhat of a disservice, I think, for years, and just, asking EMTs to memorize just lists of signs and the symptoms. They don't need to do it anymore. They could actually figure this out. They could apply these principles in determining these signs and symptoms. You know what, Dan? They become so much better at assessment is what they become. And they're going to start catching subtle things. Instead of saying, you don't want to go, sign here, I'll see you later, they're saying, wait a minute now. I'm seeing this pulse pressure that's narrow. I'm seeing this, even though your heart rate is remaining normal. No, I don't think so. I think there's something going on here. They become much better assessors, and they become much better at treatment, too. Dan, look at now where we're at with oxygen therapy. Look at what science is showing us. And I'm so proud at this point that EMS now is being based on evidence-based medicine. And now we're making treatment changes based on this, on the evidence that's being provided in the scientific literature. And Dan, in the past, as you mentioned earlier, we put everybody on an arm rebreather, we transported them. EMT nows are being required to make decisions on oxygen therapy.
Yep.
A lot of patients don't benefit, and actually it's worse for them to be on 15 liters by non-rebreather.
True.
And so that simple decision of oxygen therapy becomes somewhat difficult sometimes. What do I do? But knowing this, knowing some of these subtle things, they'll be much better at assessment and actually treating the patients.
Right. Well, our time is up, but it does come down to those decisions, whether it be using the modalities we have currently, whether it be increasing our knowledge to treat our patients better and make good decisions, or the ability to be able to do more in the future. I know that it's our intent to help EMTs and educators listening to this increase their understanding of these very important things. And on behalf of Joe and I thank you all very much for taking your time to listen to these, and hopefully we'll be able to get back to the studio and do more of these podcasts in the future. Thank you.